Welcome to this presentation on an alternate method to assess the movement of velum in a clinical setup. This research is published in Folia Phoniatrica et Logopaedica. The study conducted by S. Lokeshwar, Anu Lokeshwar, Ake Chandan and Kaustav Mandal from the Department of Speech Pathology and Audiology at Sri Devraj Aras Academy of Higher Education and Research proposes a novel forced expiration task as a more effective alternate to the conventional phonation task. Let me begin with a brief anatomical overview of the velum. The velum, commonly known as the soft palate, is a soft, muscular, and highly mobile structure located posterior to the hard palate. The knee-like movement of the velum elevates superiorly and posteriorly towards the posterior pharyngeal wall. The velum's primary function is to modulate airflow between the oral and nasal cavities. It is critical for breathing, swallowing, eating, and speech production. During speech, it must achieve complete closure of the velopharyngeal port to differentiate nasal consonants from oral consonants. When the velum cannot achieve adequate closure, we classify the resulting velopharyngeal dysfunction into three distinct categories. First, velopharyngeal insufficiency. It refers to the structural or anatomical defects. This might include cleft palate, short palate, or other anatomical variations that physically prevent adequate velopharyngeal closure. These cases often require surgical intervention. Second, velopharyngeal incompetence. It is a functional or neurophysiological deficit. Here, the structures are anatomically normal, but the neuromuscular conditions is impaired. This is common in conditions like cerebral palsy, dysarthria from stroke, or myasthenia gravis. Third, velopharyngeal mislearning. It occurs when someone with completely normal velopharyngeal structures and function learns to produce sounds incorrectly, often due to hearing loss or other factors during the critical period of speech development. Assessment of velopharyngeal function employs both direct and indirect approaches, each with distinct advantages and limitations. Direct visualization methods allow the clinician to see the velopharyngeal port directly. This can be done simply with the naked eye during oral motor examination or with more sophisticated instruments like flexible nasopharyngoscopy or endoscopy. The advantage is immediate, real-time observation of the velar movement and closure patterns. Indirect methods include instrumental procedures like video fluoroscopy, computer tomography, and magnetic resonance imaging. These provide detailed anatomical and physiological information but are typically more time-consuming and expensive. The critical limitation in many clinical settings is resource availability. Not all clinics have access to endoscopes, video fluoroscopy equipments, or imaging facilities. The gold standard for direct visualization in routine clinical practice has been the phonation task, where we ask the patient to produce the vowel "a" repeatedly. However, we observe consistent practical limitations with this phonation-based approach. Despite clear instructions and good pauses between productions, patients often completed the entire sequence in a single breath. When this happened, the velum remained in a continuously elevated or stretched position rather than moving through a natural cycle of elevation and lowering. This severely restricted the clinician's ability to observe efficient dynamic velar movement. This gap in the clinical practice motivated the development and investigation of an alternative task. Let me articulate the precise research problem that motivated the study. The primary challenge is that traditional phonation-based assessment methods are inadequate for two key reasons. First, the clients with compromised phonatory subsystems, these methods simply don't work. If a patient has dysarthria, hoarseness, vocal fatigue, or any other conditions affecting vocal production, asking them to produce repeated "a" isn't going to give you reliable data about their velopharyngeal function. Second, even in clients with normal phonation, the way patients execute these tasks create observation problems. Patients normally want to complete the activity efficiently, so they do all 5 hours in a single breath. When this happens, the velum doesn't relax between the productions. It stays in an elevated or stretched position throughout. This eliminates the dynamic movement that clinicians need to observe. You're essentially looking at a static structure rather than the function. We hypothesized that a different task, one aligned with the velum's natural respiratory physiology rather than its speech function, might produce more robust, observable velar movement. We theorized that a forced expiration task, where the patient actively breathes in through the nose and out through the mouth with force, would normally produce greater velar elevation because the velum plays a more active role in managing high pressure airflow during forced expiration. The objective of the study was to compare velum movement during two tasks, the traditional phonation task and the novel forced expiration task using direct oral visualization. We wanted to know which task produces greater or more visible velum movement. The methodology reflects careful study design to control for confounding variables and maximize internal validity. The sample size of 100 participants with 50 males and 50 females across wide age range, that is between 18 to 70 years, to ensure findings could be generalized across the adult lifespan. With respect to the exclusion criteria, we excluded anyone with craniofacial anomalies, neurological disorders, or conditions affecting velar function because these would confound the results. We excluded anyone with nasal obstruction, such as from a recent cold, which could restrict observable movement. This is a cross-sectional within subject design where each participant performed both the tasks. Half the participants did the phonation task first and half did the forced expression task first. This prevents task order effects where the first task somehow influences performance on the second. We also provided 3 to 5 minutes break between the tasks to allow physiological recovery. An iPhone 13 was used for recording a 1080 pixel resolution with 30 frames per second. The flash ensured adequate illumination of the oral cavity and maintaining a 15 centimeter distance provided an optimal view of the velopharyngeal region without the lens fogging. The rater panel consisted of 3 experienced speech-language pathologists, each with more than 5 years of specialization in areas like maxillofacial anomalies, dysphagia, and motor speech disorders. The videos shared with the raters were randomized so that they won't be able to identify the participants and the tasks. The audio was removed to maintain the blindness. The specific task instructions are simple, but each detail matters for both standardization and eliciting optimal performance. For the phonation task, participants were instructed to open their mouth as wide as possible and say "ah" 5 times with good time intervals between each phonation. The clinician demonstrated the task first so participants understood the expectation. This mirrors current clinical practice and provides a baseline comparison point. For the forced expiration task, the instruction was more detailed but remained straightforward, where the person was asked to open his mouth as wide as possible, inhale through your nose, and exhale forcefully through your mouth with a short audible sound. So repeat this 5 times and keep your tongue in a low, relaxed position while performing the task. Similar to the phonation task, the clinician demonstrated the activity first so that the patient would know how to produce the forced expression task. We developed a 5-point rating scale and was validated by 3 expert clinicians in speech language pathology. It had scores from 1 to 5, where 1 represents no visible movement, 2 slight movement, 3 moderate movement, 4 good movement, and 5 complete movement of the velum. Now, let us see a sample video of a participant who produces phonation task followed by forced expiration task. The participant in this video held his breath during phonation, which resulted in observing the poor velar movement. However, there was an active movement of velum during forced expression task. Inter-rater reliability was assessed using the inter-class coefficient, and Wilcoxon sign rank test was used for the task comparison. The gender differences were examined using the Mann-Whitney U-test. So let me highlight each key result and what it means clinically. The primary finding were FET produced significantly greater velar movement than phonation task. The Wilcoxon sign rank test yielded a z-value of -7.051 with a p-value less than 0.001. So this means the difference is highly statistically significant, where this isn't a chance finding. The effect size is large, which indicates that the practical, real-world differences between FET and PT performance is substantial. There is no statistical significance between genders across tasks. Inter-rater reliability was moderate to good. The ICC of 0.7 with a 95% confidence interval of 0.625 to 0.762 indicates that three expert raters were substantially in agreement. Importantly, this reliability was achieved across both the tasks, meaning raters could apply the 5-point scale consistently regardless of which task they were evaluating. The discussion session contextualizes why forced expression task outperformed phonation task. Let's talk about the physiological alignment. So the velopharyngeal port closure is consistent across various pneumatic activities such as speech, blowing, whistling, and yawning, all of which involves the controlled release of air from the oral cavity. With respect to historical evidences, multiple classical studies like Moll's cine radiographic research, Warren and Hoffman's work, and more recent studies documented that velar elevation during blowing activities is approximately 2 to 3 millimeters higher than during speech. The forced expression task in this study functionally resembles the blowing activities documented in that literature. When it comes to motor learning perspective, assessing velopharyngeal function in a patient with say dysarthria or motor speech impairment, asking them to perform a complex speech task confronts two systems, velopharyngeal function and speech motor control. The forced expression task reduces this confounding. It's a simple task driven by basic physiology of the velum rather than complex learned motor patterns. With respect to clinical advantage, patients with velopharyngeal dysfunction or neurological involvement may often develop compensatory airflow strategies. Using FET, which aligns with velum's natural role in pneumatic activities such as yawning and blowing, allows clinician to clearly assess the physiological integrity of the velopharyngeal mechanisms without the confounding influence of tasks involving speech motor coordination. The clinical value of this research extends across multiple dimensions. For patients with compromised phonatory subsystems, the forced expression task is transformative. Consider a patient with severe dysarthria due to Parkinson's disease. Their voice is barely audible, the phonation is breathy and strained. In this context, asking them to produce clear R's for velopharyngeal assessment doesn't work. But asking them to breathe through the nose and out through their mouth, that's something they can do reliably. Clinicians can now use FET as a complementary or alternative tool within the standard oral mechanism examination protocols. Some clinicians might use it when phonation task fails. Others might use both for more comprehensive picture of velopharyngeal function across different physiological demands. The forced expression task directly addresses the practical limitations observed with phonation task. You get dynamic movement with natural elevation lowering cycles. The velum isn't held in a stretched position. You can observe the natural function without fighting patient's physiology or overcoming task execution difficulties. This research was conducted with individuals who have typical velopharyngeal function. The sample excluded anyone with velopharyngeal dysfunction. While we hypothesize the force expression task will be valuable for assessing velopharyngeal patients, that remains to be demonstrated empirically. Applying findings to velopharyngeal dysfunction population requires cautious interpretation until future research tests force expression tasks utility, specifically in pathological populations. This research opens a practical pathway for more effective, more accessible velopharyngeal assessment in routine clinical practice.